Hello, I'm Vilma Rangel. I am a DMP student and I will be presenting my DMP project. This DMP project studied the effectiveness of an evidence-based medication guideline in the treatment of non-psychotic unipolar depression. Statistically, 8% of the U.S. population has had at least one episode of depression, as reported by the National Alliance on Mental Illness. This is the most common mental illness and, unfortunately, the cause for most suicides. However, it is still commonly undiagnosed and undertreated. The rise of suicide rates has increased by 30% since 1999, and the cost of treatment in emergency room visits is about $70 billion per year. Aside from the monetary significance, the symptoms of unipolar depression are severe that they interfere with the person's function. The disability it causes further places an economical burden, as its cost is about $326.2 billion, and it is considered the biggest rising problem. The National Institutes of Health report that only 65% of adults who are diagnosed with unipolar depression actually receive treatment. This topic holds a special interest to me because I am a practicing psychiatric mental health nurse practitioner, and it has become evident that there is no specific guidelines that prescribers use in treating unipolar depression. Unfortunately, this leads to mismanagement of depression episodes, and unfortunately, it causes patients to receive treatment that sometimes is indicated for other disorders, such as bipolar disorder. An example of this is giving a patient an anticonvulsant as a mood stabilizer instead of starting them off with an antidepressant. When patients are transferred between providers or to a different level of care, many have to start from step one instead of making a smooth transition in treatment. When there is a protocol or algorithm for treatment, it is mostly used as part of a facility policy or clinic policy, but it does not happen across the board. When a guideline or algorithm is used in treatment, the next step could be anticipated and it can be followed through if needed if the patient continues to be symptomatic. An evidence-based algorithm would serve as a guideline for prescribers to use in any setting to start the treatment of unipolar depression. Therefore, the purpose of this project was to decrease the severity of depression symptoms in patients with non-psychotic unipolar depression by applying the psychopharmacology algorithm project from the Harvard South Shore program for the treatment of unipolar depression and use the patient health questionnaire as a measuring tool. This was a quality improvement project whose objective was to decrease the severity of depression symptoms, which in turn would decrease the number of hospitalizations and number of episodes of suicidal ideation. This algorithm was applied to an adult population of males and females from the ages of 18 to 55 years that had a diagnosis of non-psychotic depression and had no medical comorbid conditions. Upon each visit, including the initial psychiatric evaluation, the patient was asked to fill out a patient health questionnaire, or PHQ-9. This is a measuring tool that is widely used to measure the severity of depression symptoms a patient is experiencing. It is scored as no symptoms, mild, moderate, moderately severe, and severe. It does become part of the patient's medical record. The expectation was that the severity of the symptoms would decrease once the algorithm was used. This algorithm was developed in 1993 and has had two subsequent revisions in 1998 and 2019. The purpose of its development was to allow a streamlined process that provides safe and cost-effective treatment in the treatment of unipolar depression. This was a quality improvement project whose objective was to decrease the severity of depression symptoms, which in turn would decrease the number of hospitalizations and number of episodes of suicidal ideation. This algorithm was applied to an adult population of males and females from the ages of 18 to 55 years that had a diagnosis of non-psychotic depression and had no medical comorbid conditions. Upon each visit, including the initial psychiatric evaluation, the patient was asked to fill out a patient health questionnaire, or PHQ-9. This is a measuring tool that is widely used to measure the severity of depression symptoms a patient is experiencing. It is scored as no symptoms, mild, moderate, moderately severe, and severe. It does become part of the patient's medical record. The expectation was that the severity of the symptoms would decrease once the algorithm was used. This algorithm was developed in 1993 and has had two subsequent revisions in 1998 and 2019. The purpose of its development was to allow a streamlined process that provides safe and cost-effective treatment in the treatment of unipolar depression. Medical algorithms are used frequently in the treatment of diabetes or hypertension. This particular algorithm from the Harvard South Shore program showed benefits of its use, including the decrease of depression symptoms, as well as improved function of the patients when it was applied. This project focused on applying the algorithm and then measuring the pre and post scores of the PHQ-9. These scores range from 0 to 27, where 0 to 4 equals none to minimal severity, 5 to 9 is mild severity, 10 to 14 is moderate, 15 to 19 is moderately severe, and 20 and over is severe. This project proposes that medication treatment be initiated at a moderate severity. In this case, it would be a score of 10 to 14. Through empiric knowledge, it was determined that the PHQ-9 provided observable data to provide a formulation to evaluate results. Ethically, treatment was provided equally to all patients, regardless of the provider's preference, which could be influenced by outsiders, such as pharmaceutical company representatives. It also provided the prescriber with an opportunity to evaluate their countertransference to objectively provide care. Lastly, the prescriber still had to provide an artistic approach when developing care plans that included outside influences on a patient's severity of symptoms. Through empiric knowledge, it was determined that the PHQ-9 provided observable data to provide a formulation to evaluate results. Ethically, treatment was provided equally to all patients, regardless of the provider's preference, which could be influenced by outsiders, such as pharmaceutical company representatives. It also provided the prescriber with an opportunity to evaluate their countertransference to objectively provide care. Lastly, the prescriber still had to provide an artistic approach when developing care plans that included outside influences on a patient's severity of symptoms. This algorithm served as a guide to start treatment, and ultimately individualized care was provided as patients were making an educated decision and continuity of care was ensured between providers. Improved patient outcomes by decreasing hospital admissions and decrease of suicidal thoughts are significant in nursing practice. There is a higher risk of completing suicide when the depression symptoms are severe. It is important for primary care nurses to recognize the severity of depressed symptoms so that treatment is not delayed as referrals to a specialist are being completed, and due to the lack of mental health providers at times can take months. The support of the stakeholders in this project was imperative to its success. The key stakeholders were the business owner and the collaborating physician of the clinic, who fully supported the project and ultimately gave his full support to apply this evidence-based algorithm in the treatment of patients with non-psychotic unipolar depression. The benefit of this project to the practice was to build a foundation that would solidify their procedures based on evidence. The literature search was done through the Maryville University Library, using several databases with the terms mental illness, depression treatment, evidence-based guideline, Harvard South Shore program, and major depressive disorder, with the use of Boolean operator such as AND. The year of publication and language was also used as parameters. These searches yielded a total of 626 articles, but it was further decreased to 10 articles that were used. The literature search was done through the Maryville University Library, using several databases with the terms mental illness, depression treatment, evidence-based guideline, Harvard South Shore program, and major depressive disorder, with the use of Boolean operator such as AND. The year of publication and language was also used as parameters. These searches yielded a total of 626 articles, but it was further decreased to 10 articles that were used. These articles shared common themes such as mental illness or psychiatric disorder, medication algorithm, evidence-based treatment, treatment as usual, not medication, evidence-based guidelines, and patient outcomes. In the medication algorithm theme, it was found that medical algorithms were developed by applying national guidelines for treatment, such as in the treatment of diabetes. Studies have shown that antidepressants such as SSRIs or SNRIs are effective, but when they are used in algorithms, they have shown improved outcomes. Such is the case as the Texas Medication Algorithm Project. Algorithms used for the treatment of bipolar disorder have also shown to decrease the cost of treatment and its alterations. Lastly, the VA has an available guideline to use in the treatment of depression, which has the potential to decrease symptoms and improve function, as it is the case with the Texas Medication Algorithm Project. In the medication algorithm theme, it was found that medical algorithms were developed by applying national guidelines for treatment, such as in the treatment of diabetes. Studies have shown that antidepressants such as SSRIs or SNRIs are effective, but when they are used in algorithms, they have shown improved outcomes. Such is the case as the Texas Medication Algorithm Project. Algorithms used for the treatment of bipolar disorder have also shown to decrease the cost of treatment and its alterations. Lastly, the VA has an available guideline to use in the treatment of depression, which has the potential to decrease symptoms and improve function, as it is the case with the Texas Medication Algorithm Project. Some guidelines are a combination of medication and psychotherapy, which also results in improved patient outcomes when compared to treatment as usual. Treatment as usual means that there was no guideline used. This evidence points to the conclusion that a guideline or algorithm always yields better patient outcomes than treatment as usual. Another theme was patient outcomes. As advanced practice nurses, we always expect positive patient outcomes. Most studies measure the time to remission. The time to remission refers to the period of time where the patient is stable or asymptomatic. When an algorithm for treatment was used, the time between symptomatic episodes was longer. Another patient outcome that was measured was a decrease of symptoms, which, when an algorithm was used, were significantly decreased. However, some studies did note that extrinsic factors can have an impact on the time to remission. The literature review done provided clear evidence needed for this project. All the studies shared a common goal, which was to improve patient outcomes. This was proved by decreased symptoms or longer remission times. The information collected and reviewed confirmed the vision of this project, which was to improve the patient outcomes with a shared methodology that provided a guideline for treatment of non-psychotic unipolar depression. Some of the studies did have their weaknesses, in which results were inconclusive due to the provider's lack of documentation. Some primary sources did not include a control group or had a small sample size. The studies in a meta-analysis had too many differences. In other cases, the patient and provider compliance were not a measured factor and only implied that guidelines were followed after the instruction was completed. Some of the study limitations included no control groups, a small sample size, no true randomization, incomplete documentation, or extrinsic factors limiting the study. The gaps in literature include the lack of measurement of the provider's or patient's compliance. Another one is the documentation was lacking, thus yielding inconclusive results. The studies that used the time to remission as a measurement never identified what was an acceptable time to remission. The concepts and definitions used were algorithm, bipolar disorder, major depressive disorder, and screen. The unfreezing change refreezing model was used. The application of this algorithm required the providers to unfreeze the current practice, make the proposed change, and then refreeze or keep that change. The following methodology was used. The clinic's providers were educated on the algorithm to be used. At each visit, the patient would fill out a PHQ-9 before seeing the provider. Once the time frame was completed, a list of patients fitting the criteria was received from the clinic owner. The effectiveness of this algorithm was determined by the decrease of symptom severity the patients reported. The setting for this quality improvement project was a mental health clinic located in the Midwest region of the United States. There was no observed procedure to ensure consistency of care for patients with non-psychotic unipolar depression, and they received benefit from an evidence-based standardized algorithm treatment plan. The participants in this project were at least 42 in number between the ages of 18 to 55 years. They had to have a diagnosis of unipolar depression with no psychosis, no bipolar disorder, no schizophrenia, and no other medical comorbid conditions. As stated before, the inclusionary criteria for this project were males and females from ages 18 to 55 with a diagnosis of unipolar depression. They could not have psychosis, medical comorbid conditions, or bipolar disorder. These were exclusionary criteria. As stated before, the inclusionary criteria for this project were males and females from ages 18 to 55 with a diagnosis of unipolar depression. They could not have psychosis, medical comorbid conditions, or bipolar disorder. These were exclusionary criteria. Human subjects were not engaged in this project as it involved a retrospective chart review. After IRB approval was obtained from the Maryville University, the data collection process started. The data collection sheets included the PHQ-9 as it was used as a measuring tool, and it collected the data from the patient, and then an all-inclusive data collection sheet with no identifying patient information. A data collection sheet was created for this project using an extensive literature review. The information gathered from the electronic medical record was de-identified and imported into the data collection sheet. The patient health questionnaire was used to screen for depression. This is a widely used tool that measures depression severity, and the support for it is due to its validity and reliability. The resources needed for this project were clinic providers, electronic medical records, office space, equipment utilized such as computer, desk, chair, and software, and the electricity use. The total cost for this project was $174.80. To protect human subjects, the clinic's exact location was not shared for this project, and the patient's information was de-identified and was ultimately eliminated in the data collection tool. The EMR had a password and was only used for data collection. This project used a quantitative exploratory design through a retrospective chart review. The quantitative data was used to evaluate if applying the psychopharmacology algorithm project from the Harvard Salesforce program in the treatment of unipolar depression decreased the PHQ-9 scores. To manage the data, the researcher collected the de-identified data and recorded it onto the data collection sheet, which was then imported to an Excel document. The ordinal independent data was then uploaded to the Statistical Package for Social Sciences, or SPSS. The Wilkinson text was used to establish and analyze the difference between the pair sets of data. The sample consisted of a total of 53 clients, in which 49% were males and 51% were females. The age ranges were used as inclusionary or exclusionary criteria for the sample. As mentioned before, the setting for this project was an outpatient mental health clinic located in the Midwest region of the United States. This clinic sees an average of 105 patients per month. Most of them are between the ages of 13 and 70. This clinic provides treatment for common mental health illnesses such as depression and anxiety disorders. This project was a quantitative exploratory design through a retrospective chart review. It compared the pre-intervention PHQ-9 scores to post-intervention PHQ-9 scores. The sample, as mentioned before, consisted of 53 charts of patients who were seen in the clinic that had a diagnosis of unipolar depression and were seen between July 1st and August 31st of 2022. As indicated in these charts, the pre-intervention data showed a standard deviation of 0.477 with a mean of 3.75 and a post-intervention standard deviation of 0.342 with a mean of 1.3. A standard deviation close to zero suggests that data points are close to the mean, which in turn makes these results more reliable. The Wilkinson rank sum test indicated that the improvement of the PHQ-9 scores was statistically significant. The facilitators of this project were the clinic owners and prescribers and the collaborating physician. The barriers encountered was finding relevant studies to support the use of algorithms in the treatment of psychiatric disorders. The approval of the first algorithm found met several obstacles. It was outdated and it required the consent of the state of Texas, and unfortunately no one in the agency could give me information of the person that was in charge of giving such consent. Therefore, another algorithm had to be found. Lastly, another barrier encountered was the time constraint in which the study had to take place due to the prescriber's schedules. The results of this project are consistent with other studies where the application of a psychotropic algorithm was effective in reducing the symptomology of the patients. The decrease of the PHQ-9 scores infers that there is less intensity and frequency of the depressed symptoms. The conclusion drawn from these results is that the pharmacology algorithm project at the Harvard Social Program for the treatment of non-psychotic unipolar depression helps improve patient outcomes by decreasing the severity of depressed symptoms. The goal was to improve the patient function by improving symptoms that can alter their efficiency at work, home, and their own personal care. The unintended consequences were that soon after the IRB approval, the researcher had to expedite the education and implementation of the algorithm in practice due to the clinic's provider vacation schedule. The collection of the data had to be completed before the scheduled dates. The level of stress to complete this project in a timely yet effective manner was truly unforeseen by the researcher. However, the strength of the project included the use of the retrospective chart review, as this was ideal to keep the costs down, and it also allowed for accessibility of records, which were valuable and accurate. The educational piece to the prescribers gave them a new method to effectively provide continuity of care when patients were seen by different providers between visits, and the precise data collection methods, random selection of participants, were also strengths of this project, as it reduced bias and enhanced the validity and reliability of the results. In essence, the major limitation of this project was time itself. The time constraint in which it had to be implemented due to the provider's vacations may have limited the benefit of the project in this clinic. The application of a psychotropic algorithm was effective in reducing the symptomology of the patients. Using a medication or treatment algorithm in the treatment of unipolar depression improved the patient outcomes and decreased the cost of care. The expectation of decreasing the PHQ-9 scores inferred that there was less intensity and frequency of the depressed symptoms. In conclusion, using this algorithm for the treatment of non-psychotic unipolar depression does help improve patient outcomes. As a post-implementation insight, follow-ups may be required at the same frequency for all patients, so that time measurement in each step of the algorithm can also be captured and considered in the project results. This project may open the door for future research on utilizing medication algorithms in the treatment of mental illness. Healthcare providers or clinicians already use medication algorithms in the treatment of chronic medical illnesses, such as hypertension and diabetes. These same guidelines could be developed for those patients that have a chronic mental illness. This project supports the need for integration of a medication algorithm in the treatment planning of those patients who suffer from unipolar depression. The implications for healthcare policy is that evidence-based medication algorithms, such as this one, could be part of the educational curriculum in the nurse practitioner programs, so the new providers can start instituting its practice in their prescribing methods. This project's results showed how effective it is to use an evidence-based medication algorithm in the treatment of unipolar depression, and as such, it should be considered as best practice to use such algorithms in the care of these patients. All DMP essentials were addressed in the development of this project. The plan for sustainability is to continue the application of this algorithm for the treatment of unipolar depression by the prescribers in the clinic. The plan for dissemination is to provide education regarding the use of this algorithm in the onboarding process for all new hire prescribers. As far as the quality assurance process, this clinic could also institute a measure to track down the PHQ-9 scores to ensure that the method is followed and effective. The following slides include the references used in this DMP project, as well as the appendices mentioned. Thank you for your time.